So good evening, everybody. I think I will begin straight away without wasting any more time. Taking on from where we left yesterday, we left at a part where we were supposed to talk about the gram-negative bacteria and the antimicrobial resistance. So I have some amount of CLSI brought into this for special tests, and the rest, the table 3, if you remember, and the rest are the options which are there for such kind of resistance. So you all know this background information. What are beta-lactamases? If you classify them as per Amler classification, you classify them into 4. And if you use the molecular one, that is the Bush-Jacobi classification, that is a functional classification, sorry, then it is group 1, 2, and 3. Now, the extended spectrum beta-lactamases can be grouped into 4 parts. One is those which are ESBL carba, the ones which are the ones which are rare. A1s are those which are present in most of the enterobacterials like Enterobacteriaceae. The M1 are those which are AmpC mediated or OXA ESBL or class D ESBL. So this is how this is an initial information that you all have. And if you look at the beta lactamases detection, you remember last class also I told you that in 2010 the breakpoints were revised so that you don't have to do double disc synergy test every time you're testing for ESBL. You just presume that if this is resistant to any of these drugs, then it is considered resistant to be possessing an ESBL. So if you want to confirm, you can do it for epidemiological purposes, and you can also do it for uh, for your own data in the hospital and for your own analysis as to what kind of uh, markers are there in your system. So for this, you can use either the Kirby-Boyer method, which is the double disc synergy, or you can use PCR methods. And we'll come to these methods in a short while. If you're using Vitek, then you use the antibiotic MICs for cefotaxime, ceftriaxone, ceftazidime, or aztreonam, and you take their sensitivity to be around 90 to 93%. So if there is then there are genotypic methods like the sequencing, PCR, DNA probes, and so on and so forth. So that we are not going to discuss too much in detail. Now, what is the criteria of performance of ESBL test? If you look at the disc diffusion or the MIC, you will realize if you are using any of these drugs in this concentration, you actually do not need to do separately for ESBL. So if they are positive for any of these, then you presume that they will have ESBL for treatment purposes. But if you're doing it for ESBL, then the double disc diffusion, that is ceftazidime and ceftazidime clavulanate and C4 and C4 clavulanate, both if you do or in alone with it necessitates that you do it for both and you see the difference. This you are already aware with, so I'm not going to change it. Now what happens in 2024 is that something has changed. It says that some phenotypic ESBL tests have limitations which affect sensitivity. You all know this, that there will be a false negative result due to co-production of AmpC beta-lactamase, and specificity, that means there will be false positive results due to hyperproduction of non-ESBL beta-lactamases if they are combined with altered permeability. And genotypic methods are limited because not all of them are FDA cleared or not all of them are easily available for diagnostic purposes. They may be available as an RUO mode, the research only use mode. Now, if you find detection of ESBL in enterobacterials in an isolate, which is actually susceptible to all carbapenems, then if you see any of these methods, then you think you phenotypic test, you presume that it is resistant to all third and fourth generation cephalosporin tested, and you don't look for any resolution and you report it as whatever phenotypic test that you found. Now, if you find an ESBL target either by NAT or by microarray or by any of the methods, and then you find that it is sensitive to all third and fourth GC, like ceftriaxone or cefotaxime, then you repeat this, either the molecular one or the phenotypic, or if there is a discordance between the two. And if it is a blood culture, then you check for mixture, that whether you've tested a mixture, and that is why you're getting this kind of discrepancy. And if the discrepancy is still not resolved, then you repeat AST with a reference method, and the conflictive genotype and phenotypic testing results should both be reported, that we got this by genotypic methods and we got this by phenotypic method. Now, if you're looking for CTX-M target by molecular method or by your microarray or NAT, and you find that it is a variable resistance to third and fourth generation cephalosporin in phenotypic method, and whereas the CTX-M target is different, then expected phenotype is there. Some CTX-M may behave like this, that you may get a variable resistance to third and fourth generation cephalosporins. So again, check here phenotypically using cefepime as a reference method. And you report what you find phenotypically and not by what you found in the NAT. The last one is that you get TEM or SHV. Yes, you've looked for these and you find these markers, and you find that there is a variable resistance to third and fourth generation cephalosporins. That means either ceftriaxone is resistant and cefotaxime is sensitive, ceftazidime is resistant, cefepime is sensitive. Then again, you presume that there is some amount of expectation of behavioral of TEM and SHV is like this. So again, you check with cefepime using a reference method, and you report what you found in the phenotypic method using cefepime. So you have these four things. Any ESBL target, it could be resistant, it could be sensitive. If you're detecting only CTX-M, then variable resistance. If you're detecting TEM and SHV, variable resistance. What do you do? Now, what is the mechanism of AmpC beta-lactamase resistance? Why we say that it is interfering? One of the things that you have to remember is that they cause inducible resistance via chromosomally encoded MC. Which organisms? These are the Enterobacteriaceae, Serratia, Citrobacter. So these are the ones which are inducible. That means the moment there is a beta-lactam, this resistance will show. Non-inducible can be there due to certain mutations in E. coli, Shigella, and Acinetobacter, or it could be a plasmid-mediated resistance, as in MDR, Klebsiella, or Salmonella, or in other species. Now, what is happening here is what is chromosomal, what is inducible, and what are the strong inducers. So if you see here, all beta-lactams are going to act on your penicillin binding protein, and they are going to create these cell wall degradation products. And in a normal situation, these are going to keep your AmpC derepressed. The control is in such a manner that it will keep it derepressed. But what happens when a beta lactam comes? When a beta lactam drug comes and binds to this penicillin binding protein, there is increased cell wall degradation product which accumulate the UDP murine chains. Once these accumulate, what it does, it stimulates the AMP repressor, which actually stimulates the AmpC. Once the repressor effect is removed, the AmpC, less like a lac operon, the AmpC synthesizes the AmpC beta lactamase. So, once more, I'll tell you, beta lactam will produce damage to the cell. It's not that it is not damaging the bacterial cell, and it will produce cell wall degradation product, which in turn will stimulate the AmpR, which is the repressor for MC. Once this gets stimulated, the repressor effect removes. It removes this effect, and AmpC gets expressed, and this is hyper expressed. So if there is a beta lactam in the system, it will get expressed. This is an inducible resistance. Now, in a normal situation, what happens is if it has a mutation in such a manner that it is producing this, there will be an hyperexpression, irrespective of the fact that there is a beta lactam in the system. What are the strong inducers? Any aminopenicillin, any amoxicillin clavulanate, first generation cephalosporin, and cefamycin. If you realize, these are the mostly the access group of drugs by WHO. These are the ones which are usually given at peripheral healthcare setup, and by the time the patient comes to you at a tertiary healthcare level or a medical college level, you will have these patients already producing this AmpC. 3GC, Piptaz, and Astronam are again strong inducers, and the drug of choice here would become again cefepime or carbapenem if they are sensitive to it. What does CLSI say on AmpC? It says that it is these Citrobacter, Enterobacter, all these Providentia, Serratia, and Yersinia, which may test susceptible to these drugs. but these agents will be ineffective because of derepression of an inducible AmpC beta-lactamase. Therefore, isolates which are even showing resistant will not be there. So remember that for these drugs, these drug bug combination do not report for beta lactams. So if there are no targets of ESBL detected and there is a resistant to third generation cephalosporin and variable to fourth generation, there are likely non-tested broad spectrum beta lactamase. So you report what you find phenotypically because that is going to work better when you have a system like this. So let's come to what are carbapenemases. So when we talk about carbapenemases, there are metallo-beta-lactamases and there are serine beta-lactamases. Remember, MBL or metallo is class B, whereas ACD are all serine beta-lactamases, and accordingly they will show their resistance. So when we have a carbapenemase resistant GNB, what do we have? We have either an enterobacteriales or a nil fermenter. Now, when you have a nil fermenter, you can have or a CRE, you can have either the effect in the porin channel or the efflux pump, or it could be one of the carbapenemases which is being produced, which could be MBL, NDM, WIMP, IMP, or KPC and OXA in case of CRE, and it could be most likely it is KPC, OXA, OXA 30, 40, 23, 40, and 58 in case of nil fermenters. So, how do you detect? You detect either by susceptibility testing in a normal way as per CLSI guidelines, either by disk diffusion or broth microdilution. And when you find them resistant, it could be a CRAB, the carbapenem resistant and Acinetobacter baumannii, or it could be Pseudomonas aeruginosa, or it could be Enterobacteriales. Now, if CRE resistant to at least any one carbapenem, that is either ERTA, Miro, and IMI, you label it as CRE. If it is Pseudomonas aeruginosa and you may find that it is resistant to any one, say imipenem or miropenem, ERTA will not work for Pseud. So in this case, you will call it a resistant isolates. But if you have a discrepant phenotype, means that it is resistant to one but susceptible to another, then it probably shows a porin loss and not a carbapenem loss, not a carbapenemase production. In CRAB, it is again resistant to at least one, just like CRE. So whenever you have okay, I'll skip this. It's anyway going to confuse. So when we look at the phenotypic resistant of carbapenem resistance, what do we can do? We can do a biochemical assay, which is Carba-NP or blue Carba or any of these carbapenemase inactivation method. The problem here is that they fail to detect porin loss or efflux pump and they cannot identify which enzyme is responsible. And of course, they require bacterial isolate. I was at a meeting in the morning today where somebody was saying, now we have a rapid method which gives results in 30 minutes to detect resistance. But remember, it still requires bacterial isolates and it has limited sensitivity and specificity. On the other hand, they are rapid, they are not very expensive as compared to molecular tests, and some of these can detect calorimetric positive signals in less than an hour from the sample. So, any questions? Keep typing them in the chat box. We'll take it up at the end. The other method is carbapenemase inactivation method, something which confuses very many students. What is a modified SIM and what is a eSIM and what does it do? So when we talk of SIM, we are talking of carbapenemase inactivation method. So what we have done here is that we take thioglycolate broth and this one tube we add EDTA. So the one which is added EDTA is called eSIM and the other tube is called MSIM. And to this you add a standardized suspension of bacteria. You add 1 microliter loopful which is there and you add 10 microgram disc of meropenem and you allow it to sit for 4 hours. What happens now is that if the isolate is producing carbapenemase, it will destroy the meropenem disc which is there. Whereas if it is not producing, then it will not destroy it. Secondly, the enzyme here, which we are testing, is a metallo-beta-lactamase. So, what EDTA will do is it will bind to that metal and make it inactive. So, now you take out the disc and you place it on your ATCC, normal E. coli 25922, which is susceptible to meropenem. So if in an MSIM, if there is a carbapenemase producer, you will not find a zone of inhibition because all the drug in this meropenem disk has been destroyed. If it is a carbapenemase positive, this is how you will see. But if it is none, then you will see a zone of inhibition because your disk is intact. Now, what will happen in eSIM? In eSIM, if there is a serine carbapenemase, then the result will be same as MSIM. That means the carbapenemase destroyed the drug. But if it was a metallo-beta-lactamase, then the EDTA here will bind to the metal which is there in the ESBL in this and will make it useless. So the drug will remain as it is and you will see this drug. So the enzyme has been rendered ineffective by EDTA. Many of you have also seen certain drug companies promoting a combination of cephalosporin with EDTA. They are using the same principle, but they are not yet licensed to use in India. So this is how it will look like the isolates. This is how it will look when you're looking at eSIM. There will be no zone. All right. So let's go to the other one. So if you have a serine one, you have metallo-beta-lactamase and you have the other. Now, what does Carba-NP do? Carba-NP, I've already told you, it detects class A and B carbapenemases with a sensitivity of more than 90%. And sometimes the weakness here is that the mucoid isolates can give you a false negative result, but it is a CLSI recommended method and it's also a FDA approved method. Then comes Carba 5R. It is approved only by FDA, not yet mentioned in CLSI. It has a very high sensitivity and specificity for classes A, B, and D. Has a rapid turnaround time. It's like any rapid card test that we do based on something like an immunochromatographic test, but it does not detect SME, IMI, or NMC kinds, which are rare ones. And then you have so many molecular ones which are there. There is a superbug CRE which detects multiple targets. There is an aid-line assay which is a multiplex PCR and reverse hybridization. There is a LAMP assay which is now available, and then there are expert Carba R depending on the company. And then lately, I think after a few years, we'll be also talking about a complete NGS for these. Now, when we're looking at our CLSI document as to what it says about carbapenem detection, remember that detection of any of these, targets which are tested, if there is a resistance to all carbapenems, you report it as you found it, considering the molecular target as per your protocol. Whether you report all three or you report one depends on you. If you detect any of the targets by molecular, same by NAT or microarray or any of the PCR, susceptible, but it is phenotypically susceptible to all carbapenemase except ertapenem. Remember that this could happen if it is a porin loss. So if the discrepancy is not resolved, you do a repeat MIC and you report it with the repeat one. Go with the phenotypic evidence if you have MSIM or Carba-NP, which you've done. Now, the table G3 talks about detection of carbapenem resistance in enterobacterials. Again, if the resistant mechanisms are KPC, OXA like WIM, or phenotypic evidence of you've already done an MC and you found this or you found this molecular, then there is no need to detection of these targets. But if the phenotypic says susceptible, then it shows that there is a likely mechanism of ESBL and AmpC along with a porin alteration so that the drug can enter and it's immediately getting either inactivated or it is not able to enter. So if the carbapenemase activity is there, you repeat AST. If not, and there are still conflicting reports, then you have to be very careful that these, whether the carbapenem monotherapy of these strains will be there or it will not be effective if you give a single drug. So otherwise, you can report phenotypic findings. Again, the same thing. If you have this and you're doing maybe a colony or from a direct blood culture and you find that phenotypic methods such as those which are described in B and C, that is Carba-NP and MSIM, are there. The bold one is in addition to CLSI 24. The previous one was there in the previous versions also. So if you have any of these and you find that they are susceptible to third generation cephalosporin but intermediate resistance, then you have to either repeat, or you repeat the AST, or you repeat this. Either of these, whatever works out better for your lab, do that. Now, if you find any of these targets and you find any of these, this thing, go for a susceptibility SDD to cefepime. If this is unexpected phenotype, then you repeat this. That you normally don't get these phenotypes, but you're getting. For example, in a country like India, it's more NDM. So if you're getting something else, KPC and NDM is the one which we are bothered about. If you're getting something else, then repeat it and take a call as per this. So if we look at the MBL, always remember now when we look for the therapeutic options, remember where are we responding. If we have a metallo-beta-lactamase, then piperacillin, tazobactam, cefepime, meropenem, ceftazidime, avibactam, and the newer combinations, the ceftolozane, tazobactam, imipenem, relebactam, or meropenem, viborbactam. Yesterday also we talked about these drugs in the tier 3 and tier 4 categories. But if you have, say, ESBL or AmpC co-production, then you may lose the efficiency of this as well. But if you have oxa enzymes, then astronam also works on this. So we'll come to these one by one. Now this is another AmpC. Remember that if there are a strong AmpC inducer, they are poor AmpC substrates. That means if the organism is producing this AmpC enzyme, it is getting induced by giving imipenem, but the patient, it's a poor substrate for them. On the other hand, you may have a strong inducer and good substrates. That means these therapies with these will be rendered ineffective. Cefepime and meropenem are weak inducers as well as poor substrates. And ceftriaxone, piperacillin, and ceftazidime are the ones which are. So you avoid ceftriaxone and ceftazidime even if literature is susceptible, and can use either non-beta-lactamase, maybe you can use fluoroquinolones for these drugs, or you can use cefepime if it is susceptible, or carbapenem if it is susceptible. So we all know about this antibiotic timeline. Earlier also in one of my talks I've covered this as to how we are moving forward and what are the new drugs which are ready for launch. The cefepime, zidebactam, cefepime, Astronam, avibactam, sulbactam, durlobactam. Now, this Astronam, avibactam, personally, I believe, is going to be a game changer. And why it is, let's see too, especially for India, because ceftazidime, avibactam for Indian population did not work very well, and we all know the reason for it. Again, cefiderocol is another new drug which is available for PGs. These newer drugs, newer GNB options for GNBs is again a short note as well as a long question. So remember these works. So cefiderocol is actually a sidrophore kind of a drug. It um, has been reported as to have a very good activity, well tolerated outcomes, and can be used for treatment of CRAB. So what it does, it doesn't get thrown out by efflux pump, it doesn't get thrown out by porin. It uses the bacterial ion transport system. So it attaches to the ion which is required by bacteria, and it uses this sidrophore or the ion transport system, and it works like a Trojan horse, goes inside and then destroys it from inside the peptidoglycan layer. Then there are various beta-lactamase inhibitors. As I said, these are going to be game changers. Sulbactam actually induces an irreversible competitive beta-lactamase inhibitor which has an ability to saturate PB1 when it is given in high doses. So high dose ampicillin sulbactam actually achieves saturation is considered 27 grams a day or 9 grams of sulbactam. Viborbactam is a boron-based beta-lactamase inhibitor, works very well against KPC. Durlobactam is again sulbactam, which works against Acinetobacter and also against D and some amount of class A and C. Avibactam can neutralize class A as well as C and some OXA48. Ampicillbactam works excellently on Acinetobacter, which are carbapenem resistant. Similarly, sulbactam, durlobactam also works. So how does it act? It is again a beta-lactamase inhibitor. So it works on the same principle that the beta-lactamase get inhibited by these two drugs. Then again, meropenem and viborbactam excellent in vitro activity against KPC and ESBL producing enterobacterials as well as CRPA, but it is inactive in OXA40 or metallo-beta-lactamase. So again, it's not going to be much useful for India where NDM is more common, but it will work on KPC. Ceftolozane tazobactam, again MDR pseudomonas, and also on some anaerobes. So it will be very good for gut infections, for anaerobic, for one of those abscesses where you expect certain anaerobe as well as pseudomonas. So it works very well on that. It's effective on both ESBL and AmpC, but it again has no activity on carbapenemases or MBL and is minimally affected by boron pump. So that is one pearl about it. So ceftazidime avibactam came with a bang, but it has no activity on NDM, and majority of our isolates, as per the available literature, are NDM. So you have to combine ceftazidime avibactam with astronam to give you a viable option for these MBL infections. Again, avibactam is a beta-lactamase inhibitor, and that's how it works, that the target alteration is not there. It is useful on MD or Enterobacteriaceae if they are not by NDM. But if you suspect NDM, like in your institution or in your, then always report it with astronam. So it is ceftazidime avibactam which is there with astronam. Sorry. So by itself, in this triple combination, ceftazidime has no effect. That is why I said avibactam and ceftriaxone as astronam is going to be a game changer, because ceftazidime will be easily hydrolyzed by the metallo-beta-lactamase that is there, and before avibactam could act, because on NDM, if avibactam will not act, or on MBL. So astronam MIC, if you get, it should suffice in the presence of avibactam. So if they are sensitive to astronam, then only it will work. So there are a lot of assays which give you combined, but actually instead of that, just use astronam MICs. They should work very well. Then the other drugs which are non-beta-lactamase is minocycline, tigecycline. We talked about these yesterday also. That minocycline has, the problem is that it has limited urine concentrations and high intolerability by patients. So they cannot be used much for UTIs or upper UTIs. Again, limited tigecycline also limited serum and urinary concentration, and this is what somebody said yesterday, that it doesn't achieve blood concentrations, but they work very well for skin and soft tissue infections, osteoarticular or osteomyelitis, these kind of situations where they have a good treatment option. And then omedacycline, ravacycline, again tier 4 drugs, you remember, work for CRAB and for CRE, which are more potent and tolerable options, and other serum levels. The oral formularies are also available in this. Why it keeps slipping. But it is not effective on Pseudomonas, and it has a potential for resistance. It has a 4-fold higher activity as compared to tigecycline. Plasmamycin, again, is a minor glycoside. हमारे पास सब मिल ही जाता है, हर जगह मैं think काफी कॉमन है, बट कुछ कुछ चीजें होती है ना, हाँ वो एकदम ऑथेंटिक होता है, वो कहाँ से पता चलता है, अच्छा So, where I was, somebody was unmuted and I lost track. So, plasmamycin again works on CRE, ESBL, or non-MBL carbapenemases, and MICs are known to remain low in presence of ESBL producing organisms. So, it will have a good effect. It's going to be, I heard it's going to be launched very soon in India, or it's already been launched. It works very well as a combination therapy for enterobacterials, for ESBL, and other non-beta-lactamases. Again, polymyxin B, lot has been said over the time. We will not go into the detail. Always remember, polymyxin B or colistin, only intermediate sensitivity is available. So susceptibility should not be reported, whatever the MIC is. So just in short to revise, what all works on what? On ESBL, everything works. All of these newer ones work. AmpC, ceftolozane, tazobactam may not work. KPC definitely doesn't work. NDM, cefiderocol will work. Lazomycin will work. Eravacycline will work. Same is with OXA48. And in Pseudomonas aeruginosa, again, there is some discrepancy that they may not work. So eravacycline definitely will not work. So I'll skip this. It's similar to that. And when we're looking for this, this is what I said, that either you can do a broth disc elution method, which is mentioned in this CLSI guidelines for 23-24, and astronome breakpoints can work with Pseudomonas aeruginosa. And this you can test either with an e-test or with an astronome disc, which is placed separately. I don't know how much can you appreciate this. Actually, it's a e-test which has this CEFTA AV e-test, and you have an astronome disc which is placed at 15 millimeters away from this e-test, and this is how it gives you. So let's see when the results are not available. So for KPC producing enterobacterials, first choice is prolonged infusion of ceftazidime avibactam, and any of these. Now these are ITSA 24 guidelines which mention all these newer drugs: Miro, Vebor, ceftazidime avibactam, imipenem, celestinin, relebactam, and cefiderocol. The ICMR guidelines tell you only about ceftazidime avibactam. If you have a documented MBL and NDM, then again ceftazidime avibactam with astronam or prolonged diffusion, or polymyxin except for UTI, or tigecycline except for blood, only for intra-abdominal or soft tissue, not even for pneumonia and for bloodstream infection because the levels are not reached above MIC, or aminoglycosides even like plasmamycin for uncomplicated infections. Whereas the IDSA 24 guidelines recommend Cefta AV in combination with astronam or cefiderocol as monotherapy. OXA 48, prolonged infusion, avibactam or cefiderocol by ITSA guideline. Now, when this testing is not available, what do? We stick to the same principle. The principles will remain the same, which have been given by ICMR, because they understand that there are various kinds of labs which will do different kinds of testing, and every testing may not be available for each of these labs. So, when you look at the CRAB infections, always remember a positive culture does not mean that it has to be treated. If it is coming for a sterile site, okay. If it is coming from a site which is non-sterile, like from a ball, from skin, or from a pus, always remember to look for any of these signs of infection. If there are no signs of active, just observe the patient. Treat only when there are inflammatory markers which are up, or there is WBC counts are up. If there is an indwelling device and it's coming from this, then of course you again replace the device or remove the device and then treat. So what does happen in CRAB as per ICMR guidelines? High dose sulbactam, as I said, 9 grams a day on its own, or as sulbactam as high as 27. Cefoperazone sulbactam or polymyxin or colistin, minocycline or tigecycline, same principle. Moderate to severe combination therapy with at least 2 agents, and mild at least a single active agent like sulbactam. Again, carbapenem resistant Pseudomonas aeruginosa. If you are looking, again, same principle, ceftazidime or cefepime, or a piptaz or a cefoperazone sulbactam if the susceptibility is demonstrated. Aminoglycosides or polymyxin till you are waiting for the results, or if there is sept. So always remember to test for these because your clinician is waiting to change your drug as per what you give. Severe infections caused by CRPA, then you have to resort to polymyxin. And if there are in a patient which has a low risk of infection, then monotherapy can be considered. In uncomplicated cystitis, ICMR still recommends the urosepsis drugs, that is trimethoprim, sulfamethoxazole, nitrofurantoin, and oral fosfomycin, a single dose if it is a E. coli only. Single dose aminoglycoside if it is uncomplicated cystitis. IDSA recommends similar kind of thing, but it also recommends fluoroquinolones. Alternate is aminoglycosides, oral fosfomycin for E. coli, colistin, cefta-AV, mirovibor, and so on and so forth. If it is pyelonephritis or complicated, then you do not use tigecycline or polymyxin. Baki, the rest remains the same as above. Always remember that in patients who are less than 1 year or more than 65, even an uncomplicated cystitis may behave like a complicated UTI. So for any infection which is outside urinary tract, tigecycline is an acceptable alternate, and avoid using aminoglycosides for lung and intra-abdominal infections. IDSA mentions that enterobacterial isolates which are not carbapenemase producers but are susceptible to this, but not to ERTA, the use of extended infusion can work. Now, in India, we usually, even the best of the labs, we routinely do not test for carbapenemase production. So then here it comes as a bottleneck because our volumes are very high. So these are the two documents that you can refer to. One is the ITSA guidelines. Please, all the exam going PGs do read these guidelines. They have certain FAQs also, which are available on many of the website. And this is the last ICMR guidance on management of this, which is available. So that's all. Thank you so much for patient listening. And oops. If you have any queries, I am most welcome to take it. Or if anybody would like to say something or ask anything. If nothing, then I will close this. Thank you, Dr. Sarabjit. Thank you for the kind words. Can phosphor be used for other organisms than E. coli? No, it cannot be used for any other. CLSI mentions only phosphor for E. coli and Enterococcus, not any other. So it should not be used. Please explain eSIM and MSIM again. Okay. So what happens is that you put uh, okay. You want me to project again or should I just tell you? Okay, I'll project. It's better to project. Where did it go? See, oh, क्या project हो गया यार? Okay, I'll just tell you. See, what happens is that if you have, you are putting the, you're taking say an ml of broth. To one you've added EDTA and to the other you've not added EDTA. Now to both you add a loop full of bacteria, allow, make a suspension, then you add meropenem disc. Now, if your organism is producing carbapenemase, then it will destroy the drug. So, whatever drug gets released from the meropenem disc or whatever is there will get destroyed. So, when you take out the disc and put it on a sensitive E. coli, which is lawn culture on a plate, and then you will not see any zone of inhibition. But if the organism is not producing this enzyme, then you will see a zone of inhibition. Now, for a bacteria which is producing this enzyme, if you add EDTA, the EDTA will chelate to the metallic center which is there, and that metallic center will not allow the carbapenemase enzyme to act. So the carbapenemase activity will be inhibited by that EDTA, and you will have a kind of a sensitive picture where you will see a zone of inhibition. So you have to remember that if it is a serine beta-lactamase, this will not happen. It will behave similar to MSIM. So eSIM and MSIM should be put together to differentiate between serine and metallo-beta-lactamases, whereas MSIM alone will only tell you whether there is a carbapenemase production or not. Nitrofurantine except E. coli, yes, you can. Nitrofurantine can be used for other organisms as well. And whereas for this, ceftazidime, avibactam both come as sensitive. See, ceftazidime, if it is an metallo-beta-lactamase producer, say an NDM is there, then ceftazidime avibactam will not be useful. It will not come. But astronam sensitivity will be there. If it is some other, say KPC or any other, then of course they both will come as sensitive. All right. Anybody else? Any questions? So I'll wind up for today, and tomorrow we have another talk on VRE. Same time, same link will work tomorrow and day after. Two more PG questions will be prepared tomorrow and day after.